Welcome back to The Explainer. Today we're tackling a massive, honestly fascinating puzzle in healthcare. Have you ever wondered why patients make the choices they do? Like, why would someone completely ignore a doctor's perfectly logical advice? Or wait, months before finally getting a strange symptom checked out? Well, we're going to unpack exactly that by digging into the sociological research behind what we call lay health accounts. It's really interesting stuff, so let's dive right in.
Okay, here's our roadmap for this explainer. We're going to start with the patient compliance puzzle, decode those lay accounts, figure out how we actually define health, look at candidacy and social norms, explore the triggers for seeking help, and finally wrap up with the modern lay referral system.
Let's kick things off with Section 1, the patient compliance puzzle, and why medical advice gets ignored.
To really ground this, I want you to put yourself in the shoes of a frustrated doctor for a second. Imagine a patient. Let's call her Kylie Nichols. Now, Kylie has diabetes, but she isn't taking her insulin regularly, and she definitely isn't monitoring her blood sugar properly. From a purely clinical perspective, this makes zero sense, right? It's genuinely dangerous. So the big question we have to ask is, why is she ignoring this absolutely crucial medical advice?
Well, as a clinician dealing with this non-compliance, you basically have two options. Option 1 is to just lecture Kylie again. Tell her why monitoring is important, throw more facts at her. But historically speaking, this approach completely fails. Option 2, and this is the sociological solution we're focusing on today, is to actually ask Kylie about her approach and her rationale. We have to uncover the hidden complexity behind her actions if we ever want to increase the chances of her sticking to a treatment plan.
And that leads us right into Section 2, decoding lay accounts. It's really about understanding that this is more than just ignorance.
Building on that second option, we have to realize that everyday patients aren't just uneducated when it comes to their bodies. Sociologist Sarah Nettleton actually hit the nail on the head here. She says, people hold complex and sophisticated theories about the maintenance of health and the causation of disease. That is a huge point. Patients don't just walk in with empty heads waiting to be filled with the doctor's orders. Their lay beliefs, or their lay accounts, have their own deep internal logic. They're heavily shaped by their unique social, cultural, and economic backgrounds.
The contrast between these two perspectives is pretty stark. On one hand, you have lay knowledge. This is highly experiential. Patients know their own bodies incredibly well, how medications make them feel, the realities of their daily lives. On the other hand, you have expert knowledge, which is rooted in specialized training and academic disciplines. The friction happens when we assume expert knowledge is the only valid way to view a health issue, and we just totally ignore the patient's lived experience.
This friction becomes super obvious in Section 3 when we ask, how do we actually define health? Is it literally just the absence of disease?
The crucial thing to remember is that not everyone defines health the exact same way. Sociological research points to three main definitions. First, there's the negative definition, where health is simply an absence of disease. Then there's the positive definition, complete physical, mental, and social well-being. But the third one, the functional definition, is where it all clicks for a patient like Kylie. This views health as your functional capacity, your ability to participate in everyday roles. So Kylie might be thinking, well, I can still go to work, I can feed my kids, so I'm healthy. For her, being healthy might just mean never taking a sick day.
Now, contrast that functional view with the World Health Organization. The WHO champions that highly positive definition, a complete state of physical, mental, and social well-being. But think about how wildly a patient's lay account might differ from that gold standard, especially if they have a lower economic status or a chronic illness like asthma or cystic fibrosis. For them, complete well-being might feel like an impossible pipe dream, so they naturally rely on their functional capacity to define their health instead.
Let's move into Section 4, candidacy and social norms. Basically, who gets sick and why.
How do people actually assess their own risk? There's this incredibly common mindset at play here. If it's going to happen, it's going to happen. You've definitely heard someone say that, right? Researchers call this lay epidemiology. Instead of looking at calculated biomedical risks like cholesterol numbers or genetic markers, patients construct their disease candidacy based on circumstances or just appearances. They see a neighbor who eats junk food all day but never gets sick, or a marathon runner who suddenly collapses. This injects a huge notion of luck or fate into their lay accounts, which can directly contradict a doctor's warnings.
And social values complicate this even further. Sociologist Peacock did these amazing interviews with women in northern England and found that their lay accounts were heavily dictated by social norms of strength and individual responsibility. She spotted three main types of accounts. First, self-blame, like, I know I should eat less fat, but I don't. Second, othering, where they judge people who they see as irresponsible. And third, no legitimate dependency. This is the intense belief that you are solely responsible for yourself, and asking a doctor for help is literally equated with weakness.
All right, Section 5, Triggers for Seeking Help, the pathway from person to patient.
So if asking for help is viewed as a weakness and getting sick is just bad luck, what actually gets these patients into the doctor's office? What actually breaks the dam?
Irving Zola's sociological framework is absolutely perfect for understanding this. Zola mapped out 5 specific triggers that push someone to seek care. Notice that just having a physical symptom isn't the main trigger. People actually accommodate their symptoms. They just learn to live with the pain. The real trigger is a breakdown in that accommodation. It could be an interpersonal crisis, or perceived interference with work, like Kylie finally going to the doctor because her untreated diabetes makes her too dizzy to do her job safely. It could be interference with social activities, sanctioning by others, or even just a symptom persisting past some totally arbitrary time limit the patient made up in their head. Like, okay, if my knee still hurts by next Tuesday, I'll finally go.
A fantastic real-world example of that fourth trigger, sanctioning by others, comes from a 2008 study by Shepard and colleagues. They looked at patients with early rheumatoid arthritis. They found that for men, a massive trigger for seeking help wasn't the agonizing joint pain. It was family encouragement, specifically getting sanctioned or essentially told to go by their wives. The social pressure finally outweighed their internal resistance to getting help.
Okay, for our final section, let's look at how this all works today. In Section 6, the modern lay referral, Dr. Google and beyond.
Before anyone even reaches one of Zola's triggers, they go through a lay referral system. Historically, this meant chatting with your mom or your neighbor about a weird symptom. But today, technology massively extends and enhances this whole system. The path from person to patient is heavily mediated by the information age.
Today's patients have this absolute wealth of information online. They jump on the internet to make a provisional self-diagnosis. I mean, we've all consulted Dr. Google, right? Then they might try to confirm it through a telephone consultation, like NHS Direct. But what's really fascinating here is that modern patients are actively managing their identity. By the time they actually sit down in front of a medical professional, they've carefully curated their lay account to make sure they are viewed as a legitimate, deserving patient, rather than just someone wasting the doctor's time.
So, bringing it all together, what does this mean for our next interaction? The absolute biggest takeaway from this explainer is that if we want better health outcomes, we have to stop demanding blind compliance. Whether you're a clinician treating a patient like Kylie, or honestly just someone trying to help a stubborn family member, you have to decode their lay account. Ask yourself, what is their definition of health? What social norms are they terrified of violating? How are they currently accommodating their symptoms? How are you going to incorporate these insights into your next clinical or personal health conversation? Think about that, and I'll catch you in the next explainer.